Usually when we think of bleeding that occurs after extraction of the tooth, we're thinking of bleeding that occurs within the first day or so after the surgery. But bleeding can also occur any time after the extraction, sometimes up to a week later due to retraction of the blood clot, which initiates new bleeding. In this video, you're going to see the case of an 83-year-old male patient who underwent an uneventful extraction of tooth number 3 due to a fracture. Ridge preservation grafting was done and a membrane was placed over the bone graft, and the patient went home and had no problems initially. This patient had a medical history significant for atrial fibrillation, and he was on coumadin for this, and his last pro time was 2.5 just a day prior to the extraction. He presented to the office on the 6th post-operative day after having been up all night with bleeding that had begun early in the evening. He'd used multiple gauze pads, and when those ran out, he used a moistened tea bag, all to no avail. When we look at this patient's mouth, what we see is a large globular mass that's known as a liver clot or a currant jelly clot. This is a large exophytic blood clot that's full of red blood cells and rich in hemoglobin. It's usually due to venous bleeding with slow oozing of dark red blood. So we're first going to go ahead and remove this blood clot in order to see where the bleeding's coming from. And to do this, we're going to give an injection of some local anesthetic. In this case, we're going to use septicaine with some epinephrine in order to get some vasoconstriction and reduce the amount of bleeding. And just like in all surgical procedures, we're going to place a throat pack to protect the patient's airway while we're working. A trick of the trade that I used on this patient before I gave him the local anesthetic was to have him rinse with a solution of tranexamic acid. This drug is also known as cyclocapron and is frequently used to control bleeding in hemophiliacs and patients on anticoagulants. It's an antifibrinolytic that competitively inhibits the activation of plasminogen to plasmin, which is a molecule that's responsible for the degradation of fibrin. It's very similar to aminocaproic acid that you may be familiar with, although it's about 8 times more active. I had the patient rinse with a 5% solution for about 2.5 minutes before I took him into the treatment room. I'm going to go in with a small curette and I'm going to gently tease the liver clot away from the underlying wound bed, and you can see that there is a little stalk where it came off of. This is what the liver clot looks like removed, just a globular mass of fibrin and red blood cells with lots of hemoglobin. There's a little bit of bleeding coming from the base at the distobuccal aspect of the where the tooth was extracted, and you can tell from the pressure that was there from all the bleeding, this caused a lot of the sutures to loosen, and so I'm going to go in and remove them since they're not really doing a whole lot anymore. They've been there for about 6 days, and they held the bone graft and the membrane in place pretty well. So we're going to go ahead and get all these sutures out so we can get a good look, nice, good, clean look at what's going on to see if we can stop the bleeding and prevent it from recurring. So you can see there on the distobuccal aspect there's just a little bit of venous oozing, and so what we're going to do is we're going to go in with just some gauze under pressure, have the patient now bite on it firmly for about 2 minutes since there's really not a whole lot of bleeding anymore. And you can see that this really slowed down the bleeding a lot. And you can also see that the bone graft is pretty much intact and that the mucosa is slowly starting to grow over it. In order to ensure that I get no further bleeding, I'm going to seal off the wound bed with some cyanoacrylate tissue glue. And there are a number of brands of this. Dermabond is mostly used for skin in the emergency room to close small skin wounds. Some of the intraoral products are Histocryl, Periacryl, and Isodent. Here I'm using Periacryl, and I like it because it comes in a little disposable pipette, and you don't really need a whole lot. You just basically drip it on one little drop at a time and let it spread. If you get too close with the tip of the pipette, you'll actually pick up some of the glue rather than laying it down on the wound bed. So you've got to do this very slowly and gradually. You want to make sure that you don't get excess tissue glue all over the place, because if you do, you can potentially seal together the patient's oral mucosa, which I don't think they would like. We're going to make sure that we've applied the cyanoacrylate tissue cement all over the grafted area and over the complete extraction site wound. And you can see if we take our spoon curette that everything is nicely adhered together, that it's almost as if there's a crust over the bone graft and over the wound. And then we want to make sure that our bleeding has pretty much stopped, so we're going to take a moistened 2x2 gauze, and it's important that it's moist at this point because if you use a dry gauze, if there's any residual glue, then actually the gauze will stick to the wound. So you take out the moistened gauze, make sure that the bleeding has pretty much slowed down, and you can see that it has. So we're going to then replace that with just a slightly damp 4x4 gauze again, have the patient bite down on that, leave that there for a minute, and then take it out, put another one in there. You can see that the first one was pretty dry, and have the patient bite down firmly, and then discharge the patient to home. So to recap, the first thing you want to do when a patient presents with some post-op bleeding, whether it's immediately after surgery or a few days later, is to first apply pressure over the wound to get the bleeding to slow down, and then you're going to go back and take a look by first giving some local anesthetic with some vasoconstrictor. That'll make the patient numb so you can actually poke around and see where the bleeding's coming from, and also the vasoconstrictor in the local anesthetic will cut down on the bleeding so it's easier to see what you're doing. Once you've got the bleeding slowed down, you're going to go ahead and carefully remove the blood clot to expose the area that the bleeding is coming from. Next, you want to try to find where the bleeding is exactly coming from and try to control it with pressure and then possibly cautery and possibly cyanoacrylate tissue glue. And finally, if the bleeding doesn't slow down, you've got to consider what the possible causes are. You've got to inquire as to whether the patient's on any blood thinners such as coumadin or Plavix or aspirin. If they're taking antibiotics, that can sometimes interfere with the vitamin K dependent clotting factors. And if they're young and this is the first time they've had surgery and they're starting to bleed, you have to consider that they could possibly have a clotting factor deficiency. For the most part, once you've cleaned away the clot and explored where the bleeding is coming from, you find that it's usually not as bad as you thought it was. Generally, application of pressure and then a few adjunctive procedures or the use of some pharmaceuticals will get the bleeding to stop. But generally, in most cases, with simple treatment, bleeding will stop.